Thank you. I'd like to use this mobile microphone. I've been sitting all day, so I'd like to move around a little bit. First of all, of course, it's a pleasure to be here and especially talk on antimicrobial resistance in abdominal infections. I think it's a very relevant topic and requires, in fact, much more attention at this meeting. And hopefully, in future years, we'll see more of this at this event. Grab this one. So instead of, I did take the liberty of slightly changing the title by removing the question mark, actually, and putting three exclamation marks. We do need to worry, and I really want to convince you in the next 15 to 18 minutes that this is indeed the case. So these are my disclosures. I also do want to disclose that about 15 years ago, in fact, I turned to the dark side. Some of you may know that I indeed had a surgical training once, but now I'm a 100% intensivist, and I do live the sad life in the ICU. So I do have a little bit of a different perspective. Now, if you think about antimicrobial resistance, you probably have seen one of these titles in the lay media. And indeed, lay media have really picked up this topic, and it's absolutely necessary because I fear, combined with surgeons being, well, less interested probably in infection management and the increase in antimicrobial resistance, this is setting the stage for what some would call a perfect storm, which could do a lot of harm to our patients. Not only patients with infections, but also patients that you may schedule for elective surgery. Not only the lay media, but a lot of international big entities took up this problem. And this is just one figure from a report from the UK that shows or tries to estimate the impact of antimicrobial resistance in the next 35 years. In the next 35 years, it's estimated that over this time, about 300 million people worldwide will die from resistant infections. Not only in the ICUs, of course, different types of infections, but you can see, for instance, that in 2050, if we don't do anything, in Europe, we will have almost 400,000 deaths because of antimicrobial resistance. And many of these patients will be dying in our hospitals, in our ICUs. So we'll have our hands full managing these patients and also protecting the other patients who are not infected or not colonized from getting the resistant bugs. So this is something to worry about. Also very worrying is, of course, that, well, if you live in a poorer area of the world, the effect will be even much, much bigger. So it's huge. For once, I would agree with this individual. We need to take the problem seriously. Something Mr. Trump undoubtedly will not like is that it's a very complex issue. You can't really put it on an A4 paper and just with a few bullets. You will, of course, know that antimicrobial resistance is not only limited to the hospitals. It's in the environments, it's in the livestock and agriculture, big problems there, a lot of antibiotic use. But that should not lead us to think we as physicians do not have to take our responsibility. In the end, the patients are in our hospitals, in our ICUs, and that's where they also get the infection. So it's not only a problem from outside the ICU, and this should not, clearly not take away our responsibility. Although it has many faces, most of us would focus on these escape pathogens, that's how they are called, although probably the top two being the enterococci and the staphylococci, probably not the biggest threat. And I think most of the threat these days comes from the gram-negative infection. And Pseudomonas and the Enterobacteriaceae, probably the biggest killers in terms of numbers, but Klebsiella and Acinetobacter in terms of resistance being a major problem. So there's a lot of mechanisms, and I'm not going to impress you with all these mechanisms involved. But what you should know, indeed, that these mechanisms, resistance mechanisms, are very mobile and can easily spread from one pathogen to another. And so it's something that is happening continuously. If you add a little bit of poor hand hygiene or hygiene, if you add globalization, with patients being transferred, well, and tourists going from one country to another, then you really add to it. I'm not sure if you know, for instance, if you travel to India, and even if you never, ever enter a hospital, there's a highly likelihood that you will be colonized with ESBL positive or other resistant pathogens without you even maybe knowing or realizing that this happens. But it is also fueled by the lack of appropriate antibiotic dosing in many situations. Underdosing is really a problem in some patients and may even select even more for antimicrobial resistance. Of course, it's very difficult to see in our patients what is happening. Okay? And you may not really understand or see how a bacterium can get resistant to an antibiotic. And this is why I really like this very nice visualization of antimicrobial resistance. It's available on the internet. The link is there. It was set up by Harvard. And this is, in fact, a very large Petri dish. This measures about 60 centimeters by 1.5 meters. And it's filled with about 15 or 14 liters of agar. And what they did, they compartmentalized it, and they put different concentrations of antibiotics, and they put microbia at the end. And there's a very nice video. This is the concentrations of the antibiotics. So at this size, there's no antibiotic, and then a 1, 10, 100, 1,000-fold increase in antibiotic concentrations. And there you will see some E. coli emerging, and it grows. And this whole process takes about 2 weeks, but it clearly shows how antibiotic exposure leads to resistance. So for once here, nothing happens. But then you see a few resistant E. coli emerge. They are selected, and they make the step towards this only one times the MIC concentration of antibiotic. And pretty quickly, you will see that they take the next hurdle. And, well, you can already guess what will be happening. In about 12 to 15 days, this whole big test tube, so to speak, was full of E. coli. Even if you have a huge concentration of the antibiotic, which initially the pathogen was 100% susceptible to, and in the end, after 2 weeks of antibiotic exposure, you have a complete resistant pathogen. I really like this video. It's very instrumental, and it shows you what can happen. And of course, you can do all types of analyses and different resistant mechanisms that develop, but it shows you that it makes a difference. Please go back to the slides. When we discuss antimicrobial resistance, we do have to acknowledge that there's quite a difference in terms of geographical spread. And these are just 2 examples that I took from the ECDC website. These are available for your country and different pathogens and different times, so you can play around a little bit with them. I've selected carbapenem-resistant Acinetobacter, Piptas-resistant Pseudomonas, and you can see, on average, there's a kind of west-southeast divide in Europe, and I'm happy to say we are in Hamburg and appear to be on the green side of this line. But this is an important thing to consider. Also, that maybe look at Spain, for instance, where Piptas-resistant Pseudomonas is not so much of an issue compared to Acinetobacter. It's higher. So there's a huge regional variability. One pathogen may be a problem in one country and not in another, and vice versa. And even within a country, of course, there may be important differences between different regions, and within regions, differences between cities, etc., etc. So it's really the local ecology that is very important. Of course, it's very difficult to look at the future, and it's only on rare occasions that you actually get to see the future today. And I want to share our experience. A few weeks ago, we got 2 patients referred from different parts of the world. In fact, Belgians who got into trauma and accidents in Eastern Europe and in Central Africa. The first one was a burn patient. When he came to our unit, he had spent 3 days in a burns unit in Central Europe, and he was infected with a VRE, with a carbapenem-resistant Klebsiella, and an Acinetobacter. 3 days, 3 major problems. The other patients come from Central Africa, 5 days after traumatic brain injury, and he got an MRSA, an Acinetobacter, and a Klebsiella, a CRE Klebsiella as well. So, and this has given us huge problems, well, not problems, challenges in terms of treating the infections, first of all, especially in burn patients who are typically in the units for quite a long time, but also protecting the other patients from getting colonized. The risk of transfer, of course, is important. So this is, for us, was kind of a, well, strange experience as how the future may look like. And I'd like to challenge you. It may be not realistic, you think, but what if there's no antibiotics left? So then we go back to, to the early previous century where we had pandemics and a lot of patients died. There would be no advances, no new developments in surgery. Any intervention would be a high risk because there's no prophylactic antibiotics anymore that work. No more implants, probably. Who's going to take the risk of putting a prosthesis in a patient? No chemotherapy or other advanced medical treatments that pose a patient at risk of opportunistic infections, irrespective of the financial cost that would be associated with this. So you may think, okay, I understand antimicrobial resistance, but so what? Do we really have to care? I don't see it, and if you don't see it, maybe, well, you haven't looked enough, or you've been living on another planet. I do often hear, well, it's not our problem, as I already mentioned at the beginning. It's outside the hospital. It's the farmers who should stop using antibiotics, and then everything will get better. That may be the case, but for now, multi-drug resistance is already a reality. And if you live in the south of Europe, you will already see a lot of extensive drug resistance with limited therapeutic options. And this post-antibiotic era is not so far away. And this is, of course, a problematic thing. There's this vicious cycle. If you have more multi-drug resistance, you're bound to use more and broader antibiotic therapies, which then again lead to more resistance. Well, and you know where this ends in the end. But of course, there will be new antibiotics. We heard it was already a statement 30 years ago. We will be smarter. And I think what happened in the past 30 years is, well, a really nice example that was kind of an optimistic attitude. And of course, there is some development, and this is just one slide. A lot of development when it comes to the gram-negative infection is in new ESBL inhibitors, and there's a great number of new drugs being developed. The problem actually is that none of them covers all of these resistant patterns, and we will find use for them, but there's not one single magic bullet antibiotic among this list. And this is only a small list of things that are coming to us. So definitely there's new antibiotics becoming available, but it will be a big challenge on how to use these agents. Now, most importantly, I do want to give you this message to take home. I think it will be the single most important threat to your patients. Not only infected patients, again, but also patients who are scheduled for elective procedures. And why is that? Well, surgical site infections, we can discuss about the timing, we can discuss about temperature and other things, but if your antibiotic is no longer effective, if your patient is colonized with ESBL, then your cefazolin is not going to work. Are we going to give carbapenems as prophylaxis to all of our patients? Well, you can imagine what will happen then, of course. Also, the empirical antibiotic therapies for patients with infections will become problematic. It's obvious that even also in community-acquired infections, we'll have to take into account that there will be more ESBL positive pathogens. It's happening now already. Some parts of the world, it's 20-30% and higher. And you have to completely rethink your empirical antibiotic therapies. Of course, local ecology probably may offer the clue here. This is just one example. It comes from a French study that looked at hospital-acquired infections and compared infections which had multi-drug resistant bacteria in gray and infections without multi-drug resistant bacteria and different empirical schemes. And you can see as long as you don't have any antimicrobial resistance, there's a lot of options. But once you have resistant pathogens on board, then a lot of the combinations that probably we are using now, look at this. I mean, this is piptaz plus amikacin, piptaz plus ciprofloxacin. They only get a very limited coverage for all the pathogens involved. So it will be very challenging, and therefore also the guidelines, such as the ones developed by the Surgical Infection Society in Northern America, will only be able to give us a framework. It will be very difficult to say, well, for this patient, you need to give piptaz plus this or that. And this table was already shown by Dr. Mazurski before, and it really shows you how difficult it will be. This is the table summarizing the empirical use for hospital-acquired infection. So it's about the general approach, and you can see there's this lot of different options. And of course, it's very hard to give straightforward recommendations, and it will only become more difficult in the future. then there is this list of potential pathogens involved. And if you have a VRE, then you need to give linezolid, daptomycin. If you have a KPC that may be involved, it's yet another drug. So it will be very complex. But this should not, of course, scare us away from antibiotic therapy in the critically ill. Let me be very clear on that. So what are the solutions? Antibiotic stewardship has been mentioned a few times already, and I do think it's very important. There's different strategies that you can use, antibiotic restriction, education, all very important. But what I do want to stress is that everybody should be involved, and also you as surgeons should be involved in these committees. I think it's really critical that this is not limited only to medical microbiology and infection disease. Everybody wants to be a champion, right? Yeah, I can imagine. Well, maybe the Italians, maybe not, I agree. But this is your opportunity to be a champion. Be a champion when it comes to infection prevention. And this is so basic, this is so critical. If you, as a surgeon, fail to follow the basics of hand hygiene, how would you expect your nurses to do the same? Right? It's very simple, and of course sometimes we need isolation and certain strategies, but the basics is our joint responsibility, and you are role models for everybody in the hospital, and it's a very simple thing to do. And the last thing I would like to discuss with you is not to expect too much from antibiotics. In some situations, well, prophylaxis, to start off with, is different from treatments. There's a very clear list of indications of situations who do not require antibiotic therapy, in whom 24 hours of antibiotic therapy is enough. And they're nicely summarized also in this iteration of the Surgical Infection Society guidelines. And I also think there are no alternatives for source control. And it's not like, well, we'll give antibiotics for a few days and we'll see what happens. Yeah? Also, in patients with postoperative leakage, prolonging, delaying the intervention will only lead to more antibiotic-resistant infections. This comes from a very recent study from Philippe Montraverse from Paris, showing you that in multivariate analysis, when it comes to the risk of emergence of multi-drug resistance in these patients, the only difference was not severity of disease, duration of antibiotics, and blah, blah, blah. It was time to reoperation. The longer you wait to intervene, the higher the likelihood that in the meantime you have selected antibiotic-resistant pathogens. So these are my key messages for this afternoon. It is an immediate and important threat to surgical practice. Better use of our antibiotics and strict adherence to hand hygiene policies, I think, are critical elements. It will affect both prophylactic therapy and also the treatment. No matter how good your surgical procedure was, no matter how fancy your endoscopic approach was, if you fail to give the right antibiotic and if you do not consider antibiotic resistance, you may end up with problems. Stewardship, again, and surgeons being involved in these stewardship programs are critical. But above all, please, I would like to plead for claiming or reclaiming, if necessary, antibiotic use. I think it's imperative that surgeons have basic knowledge of antibiotic use to optimally treat their patients. Thank you for your attention.